Oh.
Hi, my name's TJ. We're going to demonstrate placement of an NG tube for a patient. Also, this is adult health 1 for Professor Sink. So first I would check the MAR and make sure that what type of NG tube the doctor wanted and the purpose of it, what the NG tube was for. I'm going to make sure when I come in the room, the patient will be in high Fowlers. I'll have all my equipment. I've got my stuff, my NG tube, towels, syringes, pre-rip my tape. I've got gloves. I'll walk into the room, introduce myself. Hi, my name's TJ. I'm a nurse today. I'm going to be putting an NG tube in. I just want to verify your name and date of birth. Wristband. All right, we have the right patient. Okay, since she's already in high Fowlers, I'm just going to leave it alone, but I would put them in high Fowlers. Next, I'm going to check the patency of the air. I'd ask them if they've had any nasal surgeries, if they have a deviated septum, if they have any breathing problems, or and if they would be able to cooperate. I'm going to choose the left nair. It looks more patent. Next, I'm going to open my NG tube, and I'm going to measure from the tip of the nose, back of the ear, to the xiphoid process. There. So, that's our measurement. I'm going to take a piece of tape. Alright, so I'm going to place this back on my packaging, and that's set up. So now I would wash my hands, and then I'm going to go ahead and put gloves on. I'm going to lube up the first 4 inches liberally in the NG tube. Set up a towel for the patient. There's any vomiting or secretion. Alright, so I'd warn the patient about what's going to happen. May gag, may not. Then I would have the patient tilt their head back and begin to eat it. So the left nair, go in to the 4 inches, check and see the back of the throat. No coiling. If the patient were to gag or cough, more than normal, I would stop, let the patient rest, and then advance. Now I would have them tilt their head back or tilt their head forward, and have them swallow repeatedly, swallow, swallow, swallow as I advance the NG tube. If there was any resistance, I'd put slight downward pressure and try to advance. If it didn't work, then we would try the other nair. But just for demonstration purposes, this one is in. I'm going to check placement by having the patient talk to me. I check again and see if it's coiled at all in the back of the throat. And then I would aspirate and check the consistency of the content. And then, according to my protocol of my hospital, I would check the pH for the record, confirming placement of the NG tube. So we've done that. I would also, to confirm placement, I would inject fluids, sterile water, or not sterile, any kind of water, faucet water. I'd listen while injecting, make sure. And then you can also confirm placement by X-ray, and then I would measure it. Measurements fine, and then compare it to previous measurements. Now I'm going to anchor the NG tube to the patient's nose. I rip the pre-rip some tape. I would explain to the patient, try not to pull on this. This is, then we'll have to place it again. Like that. Then I would take a rubber band and a safety pin, and I would pin it to their gown with enough room to where they can move their head, and they're not pulling it out with their hands, and they can do their activities of daily life in the hospital. So that's like that. Then I would connect it to low setting of suction, and come back and do oral hygiene every 2 to 3 hours because they are NCO usually with this, so I clean their mouth every 2 to 3 hours. When I'm done with that, I would document in the MAR, make sure they're tolerating this okay, but I would document the time, the length, the size of the actual NG tube, the color and consistency of what we aspirated, and the patient teaching, and then the input and output, and that pH that we got earlier. And now for irrigation, I check, my standard protocol, see what the doctor wanted me to irrigate the NG tube with. I'm going to wash my hands and don my gloves. I'm going to disconnect my suction, which I already did. I'm going to draw up 30 cc's of air. That's our NG tube. And my stethoscope. And I'm going to listen in the epigastric area. Inject air and listen for a swooshing sound. Then we're going to draw up, for the irrigation, we're going to draw up 30 ml of water. I got my bucket here of faucet water. We're at 30. That's the 30 ml of normal saline or regular water. And then withdraw whatever I can get out. Measure it, and then discard it into another container. I'll reconnect the suction. Look at the volume that's in the suction. I'm going to check the character of the fluid that's coming out and the color. After that, make sure there's nothing out of there for the patient. I clean up all my supplies, and then I would make sure the patient is tolerating the NG tube. I would walk out of the room and document everything that happened, the type and amount of solution that I irrigated with. I would, the volume difference from the input that I gave and what I drew out. I would, what the characteristics of the fluid were that I withdrew or aspirated, if it were difficult or easy to irrigate, and then, the client's response and the teaching that I would have given them with not pulling out the NG tube. If they have any problems, to hit the call button and let me know. And that is it.